Hello, everybody. Welcome to the lecture on chapters 36 and 37. We're going to dive into chapter 36 now on antihistamines, decongestants, antitussives, and expectorants. Also, along with this information, if you look in files, you will see respiratory templates for chapters 36 and 37 in your files folder. All right, so just a little patho, as we always start pharmacology with, is patho. Histamines are nerve impulses. They're transmissions in the central nervous system, so kind of like excitability. But they're used to protect us. They're released when there's an irritant in the air, something like hay fever or grass or pollen or something that you're allergic to. And when you come in contact with that trigger, histamines are released, and they're released in copious amounts, so large amounts, and that's what causes the reactions, okay, as we will learn. So that's what causes the severe allergic reactions and the anaphylaxis. It's because of the excessive amounts of histamines. Because remember, releasing histamines is a normal part of what our body does. It's only when you come in contact with a trigger that a large or an excess amount is released. All right, so what antihistamines are we going to focus on? So diphenhydramine, and you see the other name there, but remember, for testing purposes, even when you test for the NCLEX, it's always going to have the generic name. So diphenhydramine, loratadine, fexadenidine, and ceratazine. I know these words can be difficult to say, but I always tell students all you have to do is Google how do you pronounce and type in the name of the word, and it will tell you. Why am I telling you this? Because I know these words are hard to say, like I said, but it's important that you say them correctly when you're in front of your patients. Do not mispronounce these words in front of a patient. So, even if you looked it up once, you forget how to say it, when you're in clinical, before you go in a patient's room, look it up again on how to pronounce the word so that you say it correctly. Because you do have to say to your patients diphenhydramine. Unless it's considered Benadryl in the hospital, if they don't use the generic version, then okay, it's okay to say Benadryl, but you should know how to pronounce these words. So I'm not going to read the whole slide to you, and I won't do that with any of them. So I'll just give you tips on each. So the action, we already talked about that. The action of antihistamine is to block those histamine receptors. Remember, it's normal to release histamines, but when it comes in contact with a trigger, when you come in contact with a trigger, or the person comes in contact with a trigger, excessive amounts are released. So that's when you get that allergic reaction, that severe allergic reaction or anaphylaxis. So what we have to do is give you a medication that will block the antihistamine. So notice it says it binds to the H1 blockers, to receptors, to prevent the adverse consequences of histamine binding. Okay, basically it's just saying it binds to the histamine to stop it from producing in excess amount. Okay, so who takes antihistamines? We've probably all taken one before, but allergic reactions, the pollen in these states, just, it's everywhere. Okay. Pollen is just everywhere. Pollution is everywhere. So you never know when you're going to come in contact with something that triggers the release of excessive amount of histamines. You could be a 25-year-old woman, never had any problems with allergies or anything, and then move to another state like Georgia, and all of a sudden, when it's pollen season, you start sneezing and itching and coughing. And so you just never know. It could happen at any time in life. So different reasons, that's what indication means, would be nasal allergic reaction, seasonal, like the hay fever, urticaria, we know that's itching, um, and the common cold. The common cold, because of, and remember, we're not treating the common cold. We're taking this medication because of the signs and symptoms associated with the common cold, the sneezing, the stuffy nose, things like that. It's that virus that's in your body that is causing your body to attack it and release an excessive amount of histamines. So that's when you're doing the sneezing and all of that stuff when you have a common cold. So contraindications, remember what that means. Who should not take this medication? So hypersensitivity just simply means if you're allergic to it, don't take any of these. Okay, any of these in this category, if you're allergic to them, you've taken it before, if you've taken diphenhydramine before and you've had an allergic reaction to it, you might have allergic reaction to loratadine or fexofenadine. Maybe, more likely you probably would. Let me say this one thing before I keep going with contraindications. If you go back to the drug names, notice it says sedating versus non-sedating. So diphenhydramine is a sedative medication. It's considered an older generation antihistamine. The newer generation means they were just produced after diphenhydramine. They're non-sedating. So of course, diphenhydramine was created. It was an antihistamine. It works great, but people had to still go to work. People still had to drive a car, after taking it. You don't want to have allergies so bad that all you can do is just go to sleep, So they came up with the newer generation that are non-sedative. So that's why you see sedating versus non-sedative. Notice also it says focusing on H1 only. It says that next to the word drug. What that means is H1 is the histamine release in the central nervous system. H2 are histamines released in the gut, in the belly. And we'll talk about that when we get to GI. So I just wanted to explain that in case you were looking at that and trying to say, what is that H1? What does that mean? Okay, so back to contraindications. So what I want to point out here, I don't need to keep saying to you, don't forget to, memorize hypersensitivity. That's all medications. We're never going to give you a medication that you're allergic to unless it's an emergency situation and the doctor says give it, right? The provider says give it. So what you need to remember or understand, I don't like saying remember, is that this shouldn't be given to someone that has an impaired liver or renal insufficiency. Because what do we know? We know that medications like these, 9 times out of 10, go through the first pass effect. Diphenhydramine can be IV as well, but 9 times out of 10, these go through the first pass effect. They're oral tablets, pills, capsules. So if your liver is impaired, that means it's not going to be able to metabolize it, as well as your kidneys won't be able to excrete it. And even if you take the IV version of diphenhydramine, it still has to be secreted out of your system. So they want you to use it with caution. It does not mean that they cannot have it. It just means someone with liver and renal, caution when giving them an antihistamine, as well as breastfeeding. Someone that is breastfeeding should not take these medications because they affect the baby. They cross into the baby. All right. And adverse effects. We already know allergic reaction could be one. Drowsiness. We know now that primarily stands for or goes with diphenhydramine. So with these medications, they don't really have too many adverse effects. The biggest thing here, I'm not even going to mention GI because you all know nausea, vomiting, diarrhea, right? That's all meds, just about, right? Anticholinergic is the big one. Antihistamines also have anticholinergic effects, which are drying effects. So you could have a patient complaining of dry mouth, urinary retention, dry eyes. It dries up all of your secretions. That's what these medications do. And anticholinergics are actually their own class of drugs. So as we've already learned in these few weeks, certain drugs can be in different categories. So I'll give you an example. Acetaminophen is an analgesic used for pain and an antipyretic used for fever. So now you know diphenhydramine is an antihistamine used to block allergic reactions, and it can be used as an anticholinergic drug because it has the anticholinergic effects. Okay, hope that makes sense. Interactions. Now, there's a lot of interactions here, and we like to focus on the ones that are going to be in the class of drugs that we're discussing. Because if we focus on the other classes, it takes you too far out. For instance, if I were to say one of the interactions for diphenhydramine, I know it says Benadryl there, is CNS depressants or MAOIs. Well, we're not talking about psych drugs right now. So it's not that you don't need to know that. We're not focusing on that for this material that we're teaching you. And I hope that makes sense. So what are we going to pick out of interactions that you need to focus on? Well, these medications do clash with CYP450 inhibitors. So, that's your group of enzymes that sometimes interact with medications to either decrease the effect or increase the effect. So you have to be careful with the other medications that may interact with CYP450. Okay, and there's lots of medicines, so I'm not going to go into them. I will say the big thing for this one is, like the the grapefruit juice, right? Right? That's something simple that also competes with the CYP450. And then, like I said, there's other medications that compete with CYP450, so you wouldn't be able to give those with antihistamines at the same time. It doesn't mean you can't take both meds, but you may have to take them 8 hours apart so that they don't interact, right? So you don't take them together. And of course, drinking grapefruit juice, maybe it doesn't affect you if you had a glass of grapefruit juice at 8 o'clock at night, but you took the pill at 8 a.m. Okay, may not interact, but it does say on there, do not take with grapefruit juice, right? So other than the other medications that compete with CYP450 enzymes, other than that, the big takeaway for interactions would be alcohol. Do not take these medications and then drink alcohol. That's big. Why? Because alcohol is a CNS depressant, and this medication also affects the central nervous system. So there goes your interaction. You're taking medications and drinking alcohol, and they're doing the same thing in the body. So that could be dangerous. Read more on your book about antihistamines. All right, decongestants. So there are 3 subclasses, that's what you're looking at, of decongestants. There are adrenergics, anticholinergics, there's that word again, and corticosteroids. And the names that go under each of the classes is on your screen right now. So, for instance, an adrenergic, this medication causes constriction of the arterioles, and it reduces blood flow and congestion, right? So medications that this may make sense is ephedrine, phenylephrine. Have you ever had a medication that you look on the back of the box, it's over the counter, and you're like, oh my goodness, I have a cold, I have a stuffy nose, I can't breathe, and you go to the pharmacy and they say, get a decongestant over the counter. If you look on the back of the box, you will see these ingredients: ephedrine, pseudoephedrine, and phenylephrine. So INE is the suffix, and that's how you can recognize these drugs. Now, I know diphenhydramine has an INE as well, so you just have to, memorize the difference, okay? So these medications are used to open you up, right, for congestion by constricting the arterioles, but it reduces the blood flow and congestion. Okay, then your anticholinergics, we just talked about that. So if you're congested because you're just filling up with fluids and it's just, you blow your nose, if you've ever done this, blow your nose, up, it fills right back up. You're like, I just blew my nose. Now it's filled right back up and I'm congested again. So you take an anticholinergic, and what it does is dries up those secretions. Make sense? See how it's coming together here? So the medication for that is ipratropium, and that is a nasal spray. Okay, but they have things over the counter for this too that you can put in your nose, and what is one called? Afrin, I think, that you can squirt in your nose, and it's supposed to, I don't know, dry up secretions, open you up, stuff like that. And then, of course, corticosteroids. So once again, I'm congested, so maybe my my nares is swollen. Each nasal passage is swollen, and I've been blowing my nose, and it's red and swollen and irritated and all of that. I need something to get down that inflammation because that's what's blocking me from breathing. So you have your beclomethasone, budenoside, cyanide. Remember, you have to know how to say these when you go in the room. Fluticasone and triamcinolone. Triamcinolone. Good gracious. Yeah, these words are tongue twisters when you're trying to say all of them at one time, right? Just make sure you know how to say your medications when you go in. You want to be able to say these words. You don't want to misspell words. So triamcinolone, okay? Cinolone. So sound it out, make it make sense to you, okay? So these are the 3 subclasses of decongestants, okay? So just familiarize yourself with these decongestants. So basically, I just told you, if you're congested, you can use 3 different types, 3 different classes of drugs to open you up. Adrenergics, which reduce the blood flow and congestion. Anticholinergics, which will dry up the secretions. And corticosteroids, which can reduce inflammation that may be causing the congestion. Make sense? All right. So, adverse effects depends on which subclass, right? So we know what anticholinergics do, right? Dries up secretions. So what do those steroids do? Well, if you're taking them nasally, if you're taking like a oral inhaler, of course, the dryness, it could cause dryness, irritation in the mouth and in the nose, right? Depends on how you're taking it. Adrenergics, remember what they're doing. They're constricting blood flow. So it's almost like they're squeezing something really tight. So just imagine if someone was squeezing you really tight, you would just become shaky and nervous and tremors, and you couldn't sleep if someone was squeezing you really tight. So that's my adrenergics, because remember, that's what they're doing. They're constricting the blood flow, okay? And the steroids, okay, we know they're inflammation, right? But we also know about steroids, what we've already learned, that they lower your immune system, they could cause weight gain. But just think about it for a minute. We're talking about maybe something topical, a topical steroid, or an inhaled one, or nasal spray. So we're not really looking for weight gain, Cushing syndrome, because we're not taking it in massive doses. We're not taking a pill. always remember that. Look at how you're giving the med, and that'll also help you narrow down the adverse effects. And then anticholinergics, we want to tell our patients, eat it's sour, hard candy. Suck on sour, hard candy and drink lots of fluids because it causes the dry mouth. And if they start to have problems with urinary retention, which could happen as an adverse effect, they do want to contact their provider. It's one thing to have a dry mouth and I have to eat some hard candy, right? Some sour hard candy, because the reason I'm saying sour is because it causes you to salivate when you suck on hard candy that's sour. And then that'll help you with the dry mouth. But the reason, if someone called me and said that, I would just tell them to suck on the hard candy. But if you called me and said, I can't urinate, okay, you need to come in, right? That's one of those adverse effects that we need you to notify your doctor. If you find that you cannot urinate, please call the doctor. If you find that you have a dry mouth, okay, eat some hard candy. If you have dry eyes, itching, irritable, maybe you could get something over the counter, some eye drops, they have like eye drops for, like, they call them clear eyes, what's the other word? Lacrimil or lacrimum. Those might be prescribed, but they're artificial tears. They have artificial tears. So there's certain things that patients can just get over the counter. And then there's certain things that's like, wait a minute now, we know that's an adverse effect, but that's a serious one. You need to come in. Urinary retention, that's dangerous, right? Interactions, again, none of these go with what we're talking about right now in the class, so wouldn't really focus on those. Look at contraindications. What I want you to pay attention to is the narrow angle glaucoma. The adrenergics constrict, and there's already pressure in the narrow angle glaucoma. So I don't want you to take a decongestant, specifically an adrenergic, if I have narrow angle glaucoma. Now, steroids, probably be cautious with it. Your anticholinergics, I don't think I want you to have dry eyes. You're already having problems. So you might want to be very cautious. Doctor probably won't prescribe a decongestant for someone that has narrow angle glaucoma, but you never know. You never know, right? All right. Antitussives. So what are antitussives? Antitussives just mean anti-cough, right? Anti-cough. So we've already talked about opioids. So opioids are also affect the brain. Well, they do affect the brain, right? The center of the medulla, in the center of the medulla is where there's a cough reflex. So how they use opioids is to attack that area, basically, to suppress the cough. Get it? So in the medulla, in the brain, okay, there's the cough reflex or the cough center. So what we're trying to do, because you keep coughing and coughing and you can't stop, we have to give you an opioid, which we know will go straight to that area, which means opioids cross the blood-brain barrier. Okay, that's why they're so dangerous. And they go straight to the cough center and they suppress the cough. So that's how we use opioids for cough medicine. So your two opioids for cough are antitussives, codeine and hydrocodone. Those are the two big ones that they usually use out of the opioid family. Notice I didn't say morphine or fentanyl. They don't really use those. Those aren't used for antitussives, for cough medicine. So codeine is, and hydrocodone. Okay? And you already know the adverse effects of those. If you don't, revisit your chapter 10. And then your non-opioids that we use for antitussives or anti-cough are benzonatate and dextromethorphan, okay? So benzonatate, just a prescribed common cough medicine, right? It's usually prescribed. I'm not sure if you can get it over the counter. It might even be an ingredient in over the counter cough medicines. I've never really looked that up. But dextromethorphan is prescribed, and because it's prescribed because it works like an opioid. Okay, it's not an opioid, so you don't have the central nervous system depression and all the other things that opioids do to us, respiratory depression, all of that. It doesn't have analgesic properties, meaning it's not helpful with pain like opioids are, because opioids fall under a couple of categories, right? But it does work like that, so it's a pretty strong antitussive. Okay, so indications: cough, right? And it's usually a severe cough, or a cough that lasts more than 4 or 5 days. I believe your book says something like that. So make sure you look that up. But it's usually for a severe cough, right? Well, let's put it like this. They probably wouldn't prescribe you an opioid for cough if you've only had a cough for a day or two. It has to be a chronic cough or a chronic issue that's causing you to have a chronic cough. Okay? As far as contraindications, well, it depends on which medication we're given. If we're given an opioid for cough, obviously respiratory depression, CNS depression. If we're given dextromethorphan, which is a non-opioid that works like an opioid, but it's a non-opioid. Notice it says hypothyroidism, maybe advanced cardiac disease, hypertension. So the takeaway from that, I know it says some other things, but remember, if we're not focusing on that area right now, the most important thing to take away for that would be it's contraindicated in someone with cardiac issues. That's the best way. That's how I would remember it. Hyperthyroidism, cardiac issues, glaucoma. So remember it like that. Same thing with your adverse effects. We know what opioids do. So if we mention an opioid antitussive, you already know what those adverse effects are. Dextromethorphan, it also can make you drowsy, like an opioid, right? Dizziness, and then nausea, we know that already. Benzonatate can cause sedation as well, but can also cause headaches and dizziness. So all of this kind of looks alike, so it's a little easy to remember if you want to just break it down and say, if I see an opioid used for antitussives, I already know what the adverse effects are. If I see a non-opioid, which are the only two that we're focusing on, benzonatate or dextromethorphan, I'm going to remember things like dizziness and drowsiness. And then benzonatate has headache. Okay? Just to break it down, make it a little easier. Interactions, we already know, CNS depressants when it comes to opioids. But then alcohol. Don't worry about the tricyclic. We're not doing that yet till psych. But the ETOH just means these aren't good medications to take and drink alcohol at the same time, especially the opioids. But we know that already. Expectorants. So I know a lot of you are probably used to seeing a commercial, have taken it before, maybe someone in your family. Mucinex. Guaifenesin is the word that we are using. That's the generic term, guaifenesin. You look on the back of Mucinex, that's what it's going to say is the ingredients. You look on the back of some of these cough medicines, and guaifenesin is in it, because what they want you to do is cough and get it out. Right? We're trying to suppress the cough, but we still want you to get the stuff out of you, right? So what these medications do is they cause irritation of the GI tract. So that's a big thing. But the glands are stimulated to produce more respiratory tract fluids. So it's trying to loosen things up inside of you. That's basically what it's doing. It's loosening and thinning the secretions in your respiratory tract so that you could cough it up and get it out. Okay? expectorant. I don't, for some reason, when I hear the word expectorant, I even make the motion when I say the word. It just makes me think of getting something out of you. What do you expect of me? I expect you to loosen and thin and get out of me. That's what I expect. That's a little jokey joke for you all to remember. Okay, who takes this medicine? Probably all of us have taken it before, but there's some interesting things on here you can look at. This is the good thing about guaifenesin. There really aren't any adverse effects. Allergic reaction, which we already know that just means you could have an allergy to this med, right? The first time you take any med, you can have an allergic reaction. We don't know till you take it. But GI, that's not and GI, same thing. Same thing with GI. We know this already, right? So easy peasy on that one. All right, that's it, you all. That's it for chapter 36. Look at the slides again if you would need to replay this, and look at the specific drugs that are mentioned in the classes, and then go look those up. And also use the template that has been provided for you for chapter 36. So now chapter 37, going into of respiratory drugs. So we have bronchodilators. Bronchodilators. You should automatically think of the bronchi that branches off from the trachea, and then the bronchioles, and then it's going into the lungs. All that patho should just come back to you, right? So these are the medications we're going to talk about. The adrenergics, beta adrenergics, okay, which are agonists, which means they bind and help. That's how I look at it. Bind and help. Whatever word makes you feel good, say that word, okay? We're going to talk about xanthine derivatives and anticholinergics again. Wow, anticholinergics again. So we already know those. Time on those. So your bronchodilators, your beta, or I shouldn't say bronchodilators, your beta 2 agonists. Beta 2. These are your albuterol, levalbuterol, terbutaline, salmeterol. These medications are used mainly, so listen to how I say this, especially albuterol, are used in emergency situations because they can relieve bronchospasms quick, okay? Whereas if let's say I have asthma, and I'm having status asthmaticus or an asthma attack right now, right? I feel shortness of breath. I feel my chest tightening. That's what it feels like, right? No, I don't have asthma, but I'm told. Feels like your chest is tightening. You can't breathe. Your airway is closing up. I reach for my albuterol inhaler. I do not reach for a steroid that I'm taking once daily because that takes a while to work. Whereas albuterol is going to, bam, open up those bronchioles, open them up, open up that bronchi immediately so that I can breathe. Okay, so keep that in mind. Contraindications. Okay, so anyone that has, I know we're not talking cardiac, but I just want you to see how this makes sense. It opens you up immediately. So it causes, follow me for a minute, it causes excitability, right? It stimulates really fast the beta 2 receptors. Well, beta 2 is in your lungs, beta 1 is in your heart. However, I didn't mean that to go over your head. Just go with me. However, drugs that affect beta 2, the lungs, you have 2 lungs, so beta 2, can also affect the heart. All right? So anyone with heart conditions or heart dysrhythmias, it's already going to speed up your heart rate. Okay? So if I already have cardiac dysrhythmias, I don't want to take this medication. It's contraindicated in me. If I'm at risk for a stroke, if I have uncontrolled hypertension, because it could affect the rhythm of my heart, it's going to speed things up. And if you're at risk for a stroke, You don't want to speed up or constrict the blood flow or open it up and make it bleed more. Hope that makes sense. Adverse effects, I just told you. Insomnia, nervousness, restless, tremors. Anorexia just simply means it may cause you to lose your appetite. That's what anorexia means. And then cardiac stimulations, we just said it, tachycardia and other dysrhythmias. AFib, hopefully not VFib, because VFib is dead, okay? If you're not in my class, you've never heard me say that. If you do know me, you know I always go to the extreme. Okay, give this medicine to someone that has cardiac issues, dead. Okay, and it may not cause death, but it is contraindicated in people with heart conditions. Okay, if you remember it like that, you don't have to memorize increased risk for a stroke, uncontrolled hypertension, known cardiac dysrhythmias. Just know if I see this med and I know that my patient has any type of cardiac issue, I want to question. I want to call the provider and say, Mrs. Jones has, uncontrolled hypertension, or Mrs. Jones has AFib, and we've given her albuterol, right? It should just make me think, make me question, okay? So that's the big thing. Interactions, don't go too deep with it. Just know it may interact with other drugs that cause excitability. Beta blockers are ones that do that, but we're not doing, well, actually, we are going to be talking about the heart. So yeah, that makes sense. So it interacts with other drugs that also cause excitability, beta blockers. And when we start talking about beta blockers, all of this is going to make sense because beta blockers block beta 1 and beta 2 receptors. So we'll get to that. We'll get to that. All right. Anticholinergics, I don't have to talk about these again because we did already. But this also helps you with the adverse effects because some of the other slides didn't go deep into the adverse effects of anticholinergics. So I was saying them, but now you can see them. So dry mouth may cause a cough, nasal congestions, heart palpitations, dizziness, urinary retention, and look how it could increase intraocular pressure. So I probably don't want to give this to somebody with glaucoma, open angle glaucoma. Xanthine derivatives. Easiest way to remember these guys is theophylline. Not these. I shouldn't say it like that. The only one that we're really talking about is theophylline. The way to remember what's in this drug, let me say it like that, is it contains caffeine. So right there, that helps you with your adverse effects, right there. Notice the adverse effects: sinus tachycardia, palpitations, ventricular dysrhythmias. So that tells you right there that it causes excitability like coffee, like caffeine will, right? So that's an easy way to remember it. But what it does in the body is it causes smooth muscle relaxation. So it helps open up the bronchioles, just like the albuterol. Now, it's not used as a rescue drug, but it does open you up, okay, and increases airflow when it does that. So remember that. As far as interactions, oral contraceptives. So it may interact with a woman that is on birth control pills. So that is something to remember. Okay. So you got your adverse effects. So to me, one that stands out, because we already know about allergic reaction, we already know about GI. Caffeine causes reflux. So GERD is easy to remember. Caffeine can cause tachycardia. Caffeine causes palpitations. Caffeine can cause ventricular dysrhythmias, hyperglycemia. Because of the chemicals in the medication, it causes increased blood glucose. So to me, the only one I really need to remember is hyperglycemia, because I wouldn't know that unless I looked that up. But now that Professor D has told you that theophylline has caffeine in it, everything else I understand, and I'll remember that because it just makes sense to me, right? Okay. Leukotriene receptors, the only drug. Some of you may be familiar with this drug. It's a very common drug given to people that have asthma. And it's usually given at night, Montelukast. Okay? It's usually given once daily at night. It's used for maintenance of asthma. So once again, it is not a rescue drug. Everybody say it with me. It is not a rescue drug. The only rescue drug that we've discussed today, not the only rescue drug ever in the world, but we've talked about albuterol being your rescue inhaler. You're having an asthma attack, rescue inhaler immediately. Okay? All right, so back to Montelukast. So Montelukast is used for maintenance and prophylaxis asthma, right? So if someone has asthma, but maybe it only flares up every now and then, it's used as a prophylaxis. You're not actively having asthma right now, an asthma attack, right? Maybe you only have, like, yeah, I have asthma, but it usually just gets bad in the summer, or it usually just gets bad in the fall, right? But you're taking this medication year round, once daily, prophylactically, because you're taking it so that you don't have those problems at any time, right? Or for someone that just has asthma, they have it all year round, they have it really bad, and they're taking this medication as a maintenance, along with their inhalers, probably, right? All right, allergic reaction. I'm sorry, adverse effects. No big adverse effects other than headache, nausea. We already know about that. Nausea, diarrhea. So headache would be the big one, right? So I do suggest, and I'm going to say this, go to your textbook and read up on this drug, okay? We are going to review these drugs, slightly review them in class. But we want you to come with knowledge. We're not going to be reteaching. This is your lecture. All right. Oh, I didn't know the glucocorticoids were on here. Okay. Well, yeah, steroids can be used for respiratory. I didn't even realize it was on here. Okay. So, a nurse is teaching a client who has a new prescription for beclomethasone. A steroid for their asthma, right? What are we teaching them? Going to give a pause so that you all can look at it, and then when it goes to the next slide, you'll have your answer. Right? And there is your rationale. Remember, you all have access to this all the way up until exam 2. This content is on exam 2 for right now, so you can always go back and practice these questions. If I move too fast through a slide, remember you can always put this on pause to give yourself time to read it. Okay? But for purposes of not having too much quiet time in the video, I'm not going to sit on each slide really long. Okay? But you could always pause it. So this is the one of the things that I didn't mention in the slide talking about decongestants. The one thing that you want to remember is that if decongestants are overused, it can cause rebound nasal congestion. And if you notice, if you go to a drugstore, and all of you should be doing this while you're in pharmacology. Next time you're at the store, Walgreens or any store that has a pharmacy, or all stores pretty much sell some type of over-the-counter, medication. Go to where the decongestants are and see where, and look at the back of the box, and it'll tell you not to use for more than 5 days. Because if you use it for more than 5 days, you become dependent on it, right? Remember that term, dependent? So it causes rebound nasal congestion. So it'll come back and be even worse because your body is now dependent on that. So it's almost like you need it forever now, and not really. I'm exaggerating a little, but that's what it causes. Okay. All right. So remember to bring all of your questions to class. Remember, this chapter that we just completed, chapter 37, also has a companion template in your files. Also in files are 2 documents that show you how to use an inhaler. Make sure you look at those, an inhaler alone and an inhaler with a spacer. And that information comes straight from CDC guidelines. All right. Thank you for listening to lecture.